So it's a very exciting time in protons. It's a very exciting time in radiotherapy as a whole at the moment in this country and generally, because there's a lot of exciting innovation. Protons are merely one aspect of radiotherapy, and it's very important to remember that it's not the mecca of all radiotherapy, and we need a lot of other things to make radiotherapy for different site specializations, different indications. But protons are important, and next year is a landmark thing for us in the UK, where the Christie Hospital is the first of our 2 NHS-funded facilities with high-energy protons are opening, and that'll be opening in August 2018, with UCLH coming along behind in 2020. So it's a very, very exciting time. That'll add to the expertise we already have in the UK, which people tend to forget, which is the Clatterbridge low-energy proton facility, which is a huge expertise and very, very high cure rates and very, very effective. So it's an interesting time. The journey towards high-energy protons in this country for us in the NHS started in about 2007 with the cancer reform strategy, when there was an examination of the case for exploring high-energy protons as a form of specialist radiotherapy. And over a period of time, we've managed to justify, from a clinical point of view, a limited facilities. We've managed to get Treasury and ministerial approval, which takes quite a time, as you can imagine. And more recently, in 2015, the full business case and the building and the procurement for the 2 NHS facilities has started. And building's taking place, and the cyclotron's already in at the Christie Hospital, beam lines are in, gantries are in. Really exciting, really exciting. So the question is, who are we going to treat, I suppose, is one of the most important questions. And that really stems back to what clinical evidence base is there for the use of protons. So I think it's easiest to think about this in categories of routine commissioning, which is the NHS term for there's sufficient evidence base to do this as a matter of routine. And there's a good evidence base of clinical gain for children and young adult cancers, where the biology is just very different, because the cure rates are incredibly high already, and young vulnerable tissues are more susceptible to radiation damage. So we know that we can quantify exactly what damage we give dose for dose with photons, and if we don't give that dose with photons, because the whole point is this is about dose distribution and the peculiar properties of protons that mean we can avoid irradiating normal tissue. So for children, it's just the perfect niche means of giving radiotherapy, and there's sufficient evidence base that it does what it says on the tin, which is it's as effective as photons and without giving the excess radiation dose to particularly the brain or other parts of the body. So children are a special case. Teenage and young adult is largely the same spectrum of pediatric tumours. Adults are very different, because for certain things where you're very close to critical normal tissues, such as the brain, brainstem, optic apparatus, the beam characteristics of protons are sufficiently different to allow you to maintain much higher doses than you can achieve with photons. And that's just what you need to be able to go up the dose response curve and have higher cure rates. So for brain, base of skull, paraspinal tumours, and some paranasal sinuses, there's a very good evidence base that outcomes can be better than for photons. For a lot of other areas, it's not, in adult cancers, it just isn't like that. So there's good theoretical evidence that you can give lower doses to some normal tissues, but the question is, what is the clinical gain, and is it cost effective? And under those circumstances, conventional radiotherapy has improved so much over the last few years, with VMAT, MRI Linux coming, quality assurance processes for both target volume definition, dose deposition and imaging, that the side effect rates, critical side effect rates in the majority of adult cancers are very, very low. So the incremental gain that there is to be had by protons is not maybe as much as in some of the areas I've already mentioned. And therefore, because of the very, very high cost of protons, you have to actually start to say, what is the cost-effective gain of that small change in clinical outcomes? So the way one should answer that is with clinical trials, of course. And there are certain circumstances in curative radiation therapy where one would expect for things like head and neck cancer, where dose to the salivary glands is a critical thing determining the whole of the quality of life for the patient's, the rest of the patient's life, that there may be some gain. So clinical trials in areas like that will be a high priority for us. And we've got dedicated capacity within the NHS facilities for clinical trials. There's a small sort of niche area of commissioning where you're never going to be able to do a clinical trial, and yet there's good evidence that it will be sensible on first principles to give protons, and therefore there's a thing called evaluative commissioning, which is where we can do small numbers within prospective clinical studies and monitor the outcomes to see if the gains that we expect and model with dose modeling studies actually translates into reality. So that's the plan. It's important that we collect clinical outcomes within a structure up to research level standard over the years, because some of the late effects are just exactly that. They're late, which means we've got to follow up patients and collect data for years. I suppose lastly, the other thing is that it's important to recognise what's happened in the United States with commercial pressures, where a lot of the commercial centres are actually now really struggling, because prostate cancer, which is the bread and butter of the private prostate thing, has, to some extent, the myth has been exploded with both the insurers now not covering it, as well as surgery being good, as well as watch and wait being an acceptable form of treatment. So a lot of the commercial build it and they will come model for protons has actually rather fading out in the States. And I think it's very important that we don't allow that commercial pressure with a lot of myths, frankly, about protons as being something completely different from radiotherapy, a magic bullet that suddenly gives people a last hope. This is absolutely unfair on patients. It's just radiotherapy.